Assalamu alaikum and welcome back to another episode of What's Up Doc. I'm your host, Dr. Al-Barwani, and I'm a board certified physician. My show, What's Up Doc, is a production of Muslim Network TV, the only Muslim-focused network broadcasting in North America. You can find our shows streaming on Roku TV, Apple TV, Galaxy 19, and Fire TV. You can also find us on our website at muslimnetwork.tv and on our YouTube page at youtube.com/Muslim Network TV. Today we have another exciting and very interesting episode, and that involves men's health. If you're watching this, chances are you either have a prostate or you love someone who has one. And in honor of Prostate Cancer Awareness Month, we're going to be talking about prostate cancer. Joining us in that discussion is Dr. Nadeem Rahman. Dr. Nadeem Rahman is the chairman of the Department of Surgery at St. Agnes Hospital in Fresno, California. He graduated from Duke University School of Medicine and completed his urology residency at the University of California, San Francisco. He has co-authored numerous articles and spoken at national and international meetings. Dr. Rahman's professional interests include male infertility, erectile dysfunction, male and female reconstructive surgery, and minimally invasive surgery for prostate and kidney cancer. He's regarded as a national expert in the field of robotic surgery. Welcome, Dr. Rahman. It's a pleasure to have you.
Thank you for having me. Really excited
Absolutely.
about this.
I'm sure you know, but maybe a lot in our audience don't, that September is Prostate Awareness Month. So it's quite handy that this episode's coming out.
No, it's really great for us to have that and let people know about the prostate and what's involved and getting people to understand about prostate cancer. So thank you very much for having me on.
Exactly. Thanks for joining us to talk about it. So we have had a couple of episodes regarding men's health, and we did have one most recently on benign prostate hyperplasia or enlargement. Today we're here to talk about something a little bit more serious and a little bit more potentially life-threatening, and we'll get into that, and that's prostate cancer. But to kind of recap, before we get started talking about prostate cancer, let's talk about what the prostate is and what it does in the body and where it's located so that we kind of have a background before we jump into talking about cancer.
Sure, I think that's a great starting point. The prostate's a walnut-sized organ that sits in our pelvis, and it is unfortunately surrounded by a lot of very vital things in our body. So it sits underneath the bladder, it sits on top of the rectum, the urethra where we urinate from for men, goes through the middle of the prostate and out our urethral meatus. The nerves that supply our or are used for our erections also kind of surround the prostate like a spider web. Our ejaculatory ducts and things that are responsible for orgasm kind of run through the prostate as well as the seminal vesicle. So the prostate is an organ that, while itself it's really only responsible for making nourishment for sperm or providing some of the fluid in our ejaculate, it is surrounded by a lot of things that make it quite challenging to treat. So it's kind of useful to know where it's localized.
Exactly. You mentioned a lot of important things about where it's located, making it difficult to treat and to detect any issues with as well. So now that we have a basic understanding for what prostate does and where it's located, let's talk about cancer that can affect the prostate and what cancer of the prostate actually is. As you mentioned prior to the show starting, you get that question from patients sometimes. And so I'm interested to hear what you answer or how you answer that question for them.
Yeah, I mean, I think people sometimes, because they do confuse benign prostate hyperplasia and prostate cancer, and sometimes they'll confuse, treatments for both. And so it does create some confusion. Mm-hmm. So as you alluded to, as every man ages, their prostate has a natural tendency to enlarge. That is benign growth that occurs, and it does not really spread to other areas. Cancerous growth of the prostate is different. It tends to occur in a little bit different part of the prostate, more on the peripheral part of the prostate. Mm-hmm. It's an abnormal growth of cells that tend to want to spread to other areas and can cause local invasion or destruction of other organs. And so it's important to kind of understand that difference. And because, as you mentioned and alluded to, because of the location of the prostate, many times, prostate cancer is not really going to be detected or cause symptoms until it's, almost too late. So it's just important to kind of understand what the prostate is, what the difference is between prostate cancer and benign growth, and so it's a useful way for us to get started.
Excellent. Thank you for sharing that. Now, I read that the cancer of the prostate is one of the top 3 diagnoses in men, or top 3 cancers in men. Can you give us a little bit more detail about the numbers behind that?
Yeah, prostate cancer is actually one of the most commonly diagnosed cancers in men. And so for all men that's not related to skin cancer, it's actually the most common cause of prostate cancer. So that equates to about 200,000 men a year being diagnosed. In the United States, just from being born in America, your risk of getting prostate cancer is about 1 in 8.
Wow, that's pretty high.
Sorry,
no, I'm saying that's pretty high.
Yeah, that's very high. So, and that's actually the 3rd leading cause of prostate cancer death. And so you get roughly about 30,000 men a year die from prostate cancer, and equivalent to about like maybe 1 in 30 men. So it's important to kind of understand that data, so we kind of understand how serious a condition this can be.
Mm-hmm. I completely agree with you. I think having an idea of those numbers gives us a sense of how it can happen to, like you said, 1 in 8 men. That's not a large number. If you have a small gathering of friends, you've got your 1 in 8 right there. And I say that not to scare people, and I'm sure you don't as well, but because this is a cancer with early detection is very much treatable. I think it's really important to just be aware of that, which brings us to the question of screening. Just like with any kind of cancer, breast cancer, cervical cancer, the screening component is really important because that tells us, before you even start to have symptoms, really gives us a chance to detect something early, or to, if there are ways that we can prevent once some kind of detection of precancerous lesions are detected, we can prevent it from developing into cancer. So similarly, when it comes to prostate cancer, I know that there's been a lot of debate in the medical field about what that screening should look like, and there's frequent changes to that. So give us an update on what is the most recent recommendation for screening for colon cancer, as well as who is eligible, who should be thinking about this.
Yeah, I think just to kind of get a better understanding, prostate cancer affects, men, and and definitely as a man gets older, his risk factors for prostate cancer worsen. So elderly age is a risk factor for prostate cancer. I think African American men tend to have higher risks for prostate cancer, and when they are diagnosed, their risk of having more aggressive cancer and cancer death is also higher. So those are all kind of involved in our evaluation for who should be screened. And as you're aware, like the screening process has kind of gone through a lot of changes over the last 10 or 15 years. Initially it was any man that was over 50 should be screened for prostate cancer. Now we kind of look at each individual person and kind of try to get an assessment from them as to whether or not they have individual risk factors themselves, and then that determine their age, what age we should begin screening men for prostate cancer. So just to give you an example, if I see a very healthy man who has in his 50s, but he has a very strong family history of prostate cancer, I'll highly encourage that person to kind of get screened for prostate cancer early with the rectal examination and a PSA. For an African American man, I would probably screen that man much earlier, maybe in his mid 40s or even early 40s, depending on how much risk factors they have or what family history he might have, and that just has to do with prostate cancer risk factors. So it really depends on each individual person's particular risks. One thing to kind of remember is that it's not just a family history of prostate cancer that increases a man's risk for prostate cancer, but if a man has a woman with breast cancer, especially if she was, with some of the oncogenes that are out there, like the BRCA1 gene, that will also increase a man's risk for having prostate cancer. Similarly, there are certain risk factors with colon cancer and ovarian, and endometrial cancer. So it's important to get an assessment on each of our patients individually, and then we kind of individualize that screening based on their particular factors.
I really love that. And I'm always for individualized medicine because, just like you said, we can't really just kind of wave a hand and just apply the same kind of medicine to everybody. We really have to be individualized with respect to screening and really with treatment and things like that as well. So I appreciate you sharing that with us as far as the screening component. Now, you mentioned the genetics being a big part of what puts you at a higher risk for requiring potentially an earlier screening than somebody else with lower risk factors. And let's go down that road. What are some other risk factors besides family history and some of the things you mentioned, like oncogenetic factors, that make someone at higher risk for developing prostate cancer?
Well, as I kind of alluded to first, just to reiterate, at elderly age. So as every man gets older, they do have a higher risk of getting prostate cancer. Smoking has an increased risk of prostate cancer in men. And then, as when we get individually with family history, we always look to see who in a man's family has had prostate cancer. So let's say I have a man who has a father with prostate cancer, but he was diagnosed, late in life. Well, that doesn't necessarily increase his risk for prostate cancer. But if a man has a father with prostate cancer that was diagnosed relatively early, usually before the age of 70, well, that can increase his risk for prostate cancer by a factor of 2. Similarly, if a man has a brother with prostate cancer, you can get an increased risk of almost a factor of 2 of you developing prostate cancer. And then if you have a father and brother with prostate cancer, that can even, almost quadruple your risk for prostate cancer. So those men are, I tend to screen very, very early if I do have those type of patients in my practice. Similarly, with patients who have, as I mentioned, with breast cancer, we always discuss the oncogenes and the BRCA genes. But I think just getting a good history on those patients and finding out what family history you might have. We also know that diet, lifestyles play a big factor. Being overweight tends to increase your risk for prostate cancer and possibly even increase your risk of higher risk prostate cancer. So those are all factors that I try to educate my patients on to kind of make sure that they are aware of things that they may be able to do. And we, for instance, in diet, patients who are somewhat overweight, I tend to encourage them to exercise more regularly, to try to get regular exercise, to try to keep themselves in shape. We have this concept now in urology that a heart healthy diet is going to be a prostate healthy diet. So we're always encouraging our patients to kind of keep their hearts healthy, and that will in turn keep their prostates healthy.
Excellent, thank you. And I guess thank you for answering the question I really meant to ask, which is, as far as risk factors, things that we can control. So touched on that diet and lifestyle is what I was really trying to ask. And so having a healthy diet, which of course, I feel like that's the easy, I don't know if it's the easy answer, but it's the answer that we give for a lot of conditions in medicine is healthy diet, staying within a healthy weight, being active. I feel like those are things that for a lot of conditions in general and that we've had on this show have been things that help to either prevent or to treat or reduce your risk. Are there other things that can mitigate your risk for cancer besides the things you mentioned, or some things that such as supplements or things that you can take to help reduce your risk if you are in the high risk category? Or in the case of someone who may not be high risk but wants to prevent just the age-related risk to reduce that as well?
Yeah, I mean, urology has been very proactive about having a lot of studies available or done to see what can be done to help prevent men's risk for prostate cancer. So they've done, various studies with supplements like selenium or vitamin D and other supplements out there. And, the data for those supplements have not been conclusive enough to really advocate those on a regular basis. And that's where, we tend to step back in the field of urology and say, let's try not to maybe push for one particular supplement over the other, but try to just, as you mentioned, try to have a diet with a healthy lifestyle, exercise regularly. That being said, we do have a large portion of patients with prostate cancer that have kind of lower risk cancers that we tend to watch, and we've done a lot of studies on those types of patients. And we do know that, for instance, diets with primarily a plant-based source of nutrition tend to cause less progression of prostate cancer. We know that meditation with trying to keep yourself mentally happy as well has been shown to decrease your risk. There was a study done maybe about 15 or 20 years ago. It was done at UCSF, where they took men with low risk prostate cancer and they had them go primarily on a plant-based diet or a vegan diet. They had them do daily exercises, and we had them do a daily yoga, and we could see that a dramatic decrease in their prostate cancer progression. So that was all very insightful, and I think there have been many studies over the years that talk. Well, we actually have had identical twins, and some twins will have more healthy lifestyle choices, and they may not develop prostate cancer, whereas the identical twin cohort had. And so those all tell us how important diet and lifestyle factors can be. So if you do have that strong family history, I think it's important to really focus in on some of those changes.
I love that. Thank you so much. Very helpful. And the reason I really enjoy hearing that from you and these studies that you mentioned is that a lot of times when we have a family history for something, it can be very easy to say, well, it's something that I'm going to get. There's nothing I can do about it anyway. I might as well write it out or continue X, Y, and Z bad habit or bad lifestyle, or unhealthy, I should say, not bad, but that may lead to issues down the line, when in fact, even if our genetics may dictate something, being able to make changes that can affect that, like eating healthy, exercising, meditating, so important. I need to put that on my list of things to do. Yeah. Not that I have a prostate, but I understand that it's pretty good in general. Yeah. But just it underlines how important environment can and our lifestyle can have over our genetic expression, I guess. Right. So with that, Dr. Rahman, we do need to take a quick break here. And we'll be back in just a few minutes. You're watching What's Up, Doc, and we'll be back after this short break.
There are 16 million children struggling with hunger in America. That's 1 in 5 daughters, sons, neighbors, and classmates who don't know where their next meal is coming from. Yet billions of pounds of good food go to waste every year. It's time we do something about it. Feeding America is a nationwide network of food banks that helps provide meals to millions of kids and families in need. Visit feedingamerica.org to help them feed even more. Together, we can solve hunger. Together, we're feeding America.
When times get dark, we can't see the help that's all around us. Let 211 be your guiding light for help with food, healthcare, and other resources.
211, how can I help you?
Call 211 or visit 211.org. 211, get connected, get help.
Something more than a birthday is happening here. Once you can see it, you can help. The sooner you recognize the signs of autism, the sooner you can make a lifetime of difference for your child. Start by answering a few simple questions at screenforautism.org.
Assalamu alaikum and welcome back to What's Up, Doc. I'm your host, Dr. Aalia Al-Barwani, and today we're joined by Dr. Nadeem Rahman, and we are talking about prostate cancer. So Dr. Rahman, before the conversation, we were talking about screening and things that put people at a higher risk for requiring screening, as well as some things that people can do to help reduce their risk. Now that we've talked about that, let's talk about the screening process itself, because just as there was controversy about who requires screening when, there's also controversy about how that screening should be done.
Right.
So let's talk about that next.
Yeah, so the biggest thing for screening, has to do with when we're having a conversation with our patients. We're always needing to talk to them about a test called the PSA test. The PSA test is it's a blood test. It's standing for prostate-specific antigen.
Mm-hmm.
It's an enzyme made by the prostate. It's very useful in screening for prostate cancer, as well as monitoring treatment algorithms. So we typically do recommend that as a first line for screening for prostate cancer, along with the good physical exam with the good rectal exam. So, as I mentioned, the prostate sits on top of your rectum. So the best way we can actually detect for that on a physical is by digital rectal examination. But unfortunately, less than 15% of cancers are diagnosed that way, and most of them are diagnosed, if screened appropriately, with the use of the PSA test. So we typically always recommend that when a patient is worried about prostate cancer, they have that discussion about the PSA test with their primary care doctor or their urologist, and then get that test done at least on an annual basis, especially, as we talked about, the different risk factors, depending on their age, depending on their risk factors. And then, there are other tests that are out there that, I think can be useful to make the PSA test a little bit more accurate. Typically speaking, once a PSA test is drawn, we kind of look at the PSA test and kind of analyze it in terms of its level relative to your age. And we also look at, if you're getting multiple PSA tests done on an annual basis, we look to see how does the PSA change over the years. We call that the PSA velocity. If those numbers are abnormal, they will oftentimes lead us to do additional testing. Now we're typically doing MRIs of the prostate, along with other tests such as other markers of the prostate. There's a test called the urine PCA3 test, and that the urologist may want to order. But we specifically, if a patient does have an abnormal PSA test, we will recommend a prostate MRI. Now, prostate MRIs have gotten much more accurate over the last 5 years based on the strength of the magnet of the MRI. And that allows us to really get a good visualization of what's happening inside the prostate. And if we see abnormalities on the rectal examination, or if there's really just a high level of PSA, that will probably lead us to do a prostate biopsy, which then can lead us to a diagnosis of prostate cancer.
That's very helpful, Dr. Rahman. So from just to summarize kind of what you said, because there are two different ways that the average person, at least when they come into my office, that they are aware of when they say, can you check my prostate? Sure. They're either talking about checking it in the blood work, which is the PSA, as you mentioned, or the rectal exam. But individually, it sounds like they're best when combined, as opposed to on their own, because the accuracy or the sensitivity of the test individually may not be that high. I do know that with the PSA, there can be other conditions that can cause it to be elevated. So that's really important, that piece that you said, where there is follow-up in imaging and other testing that can be done to confirm or to follow up an abnormal PSA.
Right. I think one thing which I tend to emphasize to my patients, but doesn't necessarily is that just an elevated PSA doesn't necessarily mean you've got prostate cancer. And that's where the additional tests are oftentimes needed. And just to kind of follow up on your excellent point, other conditions do cause the PSA test to elevate. So, if you've had a recent urinary tract infection, if you've had a recent, prostate infection, your numbers can be elevated. And the PSA number can elevate, just as we talked about before, from the prostate just growing in a benign fashion. Mm-hmm. And, one thing that we don't oftentimes tell our patients, but having recent sexual intercourse or ejaculation before a PSA test can sometimes cause the numbers to go up. Interesting. Patients will oftentimes come in and PSA will have changed over the course of a year, and I tend to ask them those questions. They say, "Oh yeah, I had sex right before my test was done." I said, "Well, that could be a cause of your PSA test to be elevated." So those are all important things to know about. So
that is absolutely something that
common really no one really knows about it.
Yeah, exactly. So you did mention something about prostate biopsies as one of the tests to kind of, excuse me, continue the investigation for an abnormal PSA or abnormal exam. Is that the mainstay for diagnosis for prostate cancer?
Yes, that's
in your practice.
Pretty much most urologists, diagnose prostate biopsies with diagnose prostate cancer with a prostate biopsy, and the prostate biopsies now typically are, as I mentioned, the MRIs are being done so in such high volume that we're doing a special type of prostate biopsy called an MRI Fusion Biopsy. So, what we typically do is we identify lesions that are seen on an MRI. We then will go to do a procedure on a patient with a transrectal ultrasound, and then kind of download that MRI picture onto the ultrasound picture to help kind of localize those abnormal lesions so we can target those biopsies. So it's a very specific way of increasing our diagnosis of prostate cancer. Many times, some urologists don't have access to some of that technology, and they'll still do a traditional transrectal ultrasound with biopsy. So an ultrasound probe that's placed into the rectum and used to visualize the prostate. Then they take little needle samples from the prostate that way. But
I imagine under anesthesia.
I offer it for all my patients under anesthesia. A lot of urologists will still do it under local in the office, and then that can sometimes be painful. But if it's done if it's a proper prostate block or under complete numbness, then usually it's very well tolerated.
Great, and I mentioned that specifically because I do perform digital rectal exams, and I usually have to show the patients how small my hands are for them to allow me to do that.
Right.
So imagine it, and I'm imagining having to explain to a patient that an ultrasound will be placed, and as you just mentioned, the biopsies and the needles, etc. I can just see them leaving and not coming back. So if I can reassure them that they're going to get some anesthesia.
You're absolutely right. I have a partner he wears like a size 8.5 glove, and that's his biggest complaint when he says, "Oh, Dr. Rahman, can you do my test? Because I don't want him to do my prostate check."
Exactly.
Yeah.
So usually between myself and a male colleague, they'll usually pick me for that exam. So once a diagnosis is confirmed with the methods you mentioned a few minutes ago, tell us how cancer of the prostate is staged, and what are the next steps in confirming and moving before moving, or as you move into treatment, I guess.
So one of the interesting things about prostate cancer is that most cancers, when you do a biopsy, let's say of a kidney or something, typically you'll have kind of a uniform type of cancer cell that's kind of seen. So you'll get a one particular grade. Prostate cancer is a little bit unique because within a biopsy specimen, you can see different levels or different types of aggressiveness seen. And so, patients sometimes get confused because you'll see a biopsy report that says, grade 3+3 or 3+4, rather than just having one number. And what happens is the pathologist, when you take a specimen from the prostate through the technique I mentioned, they usually put it under a slide, and they'll analyze the cancer itself, and they'll kind of look at the different parts of that specimen, and they'll kind of look at the two most common aggressive forms of cancer, and they grade those cancers on a scale of 1 to 5. 5 being the most aggressive type of cancer that typically we want to spread. Typically it's graded between 3 and 5. Usually grades 1 and 2 are not really given a diagnosis anymore. So usually it's a grade 3, 4, or 5. And then they'll find the second most common spot on that specimen and grade it also 3 to 5. And so you'll have specimens that are graded 3+3 for a grade 6, and you'll have other specimens graded as a 4+3 or a grade 7. Well, a 4+3 can be much, much more aggressive than a 3+3. So, and as urologists, we kind of know that. Pathologists, we kind of know that. But sometimes patients may not understand that, and that has to do with how aggressive a 4 is compared to a 3. And so, it's just important for patients to understand when they see that report and you see those numbers. It's related to the fact that within each specimen, you can actually have different grades even within that specimen. So they grade typically 1 to 5, and it's graded like as I mentioned, with up to 10, but it's usually between with the two most common. And so that's one of the factors that we look at when we grade cancers. Stages of cancer will also then be determined based on imaging and based on examination findings. So if a cancer can be found on rectal examination, then you can typically grade that cancer a little bit more aggressively. If a specimen is found on both sides of the prostate, it's graded as graded differently as well. So typically a stage 1 type of cancer is usually where it's localized to just one side of the prostate. Stage 2 cancers where it's on both lobes of the prostate. A stage 3 type of cancer will have gone just beyond the prostate. And then stage 3B is where it goes beyond the prostate into those organs that are responsible for ejaculation, the seminal vesicles. And stage 4 cancers typically will go to other parts of the body, like the bladder, the rectum, or the lymph nodes that are there. So all those are typically very common stages of cancer, and it's, I think, important for patients to understand those differences.
Wow, very thorough. And so I think that for those who definitely, with the diagnosis of cancer, a lot of people are usually very overwhelmed. I think that the way that you broke it down, though, is very helpful to understand that not every form of cancer is an aggressive form of cancer, that there are stages and grading that goes into that within the sample of the cancer itself. As you said, there's a lot of differences, or there's a lot of heterogeneity, as you said, in the specimen itself. Yeah. And then grading goes really beyond as far as, how far outside of the local area is this cancer reaching, is what I understand from that, or how to kind of break it down a little bit for our patients. Yeah. But of course, this is something that if you do have a diagnosis of, that you can always go over with your doctor. Dr. Rahman, I'm sure you're very well versed at breaking these reports down for your patients in a way that they're able to understand. So I encourage any of our audience who might be going through that to have that discussion with their specialist as well.
Yeah.
I definitely want to, did you want to add something?
Oh, I was just going to say, when we type of look at cancers, as I was mentioning, a grade 3+3 or a grade 6 prostate cancer tends to be more on the lower aggressive side, and it's considered low grade. A grade 3+4 or 4+3 would be more considered an intermediate grade, and anything with a 4+4 or grade 8 or above would be considered higher grade. So those are just important things to kind of remember as well. So grade 6 kind of low grade, grade 7 is kind of intermediate, 8 or above is considered higher grade.
Okay, some key numbers there. Thank you. So I want us to talk about the next step, which is treatment, of course. But before we do that, we do have to take a quick break here. So We'll be back. You're watching What's Up, Doc, and we'll be back after this short break.
A free 3-minute online chat can give you the personalized tips you need to start boosting your retirement savings today.
Dad, they took over my bedroom. Come on. Okay, Dad. 1, 2, 3.
Are you okay?
I'm fine, dear.
Your hero needs you now, and AARP is here to help. Find the care guides you need at aarp.org/caregiving.
I am what hunger looks like in America. I am an 8-year-old girl who's not excited for the last day of school, because this may be the last time I'll have lunch.
Till September.
I am a single father of 2 who works 3 part-time jobs, and that's still not enough to put food on the table. I was created by artificial intelligence from faces of the 1 in 8 Americans who struggle with hunger.
Feeding America, 200 food banks strong.
Assalamu alaikum and welcome back to What's Up, Doc. I'm your host, Dr. Aalia Al-Barwani, and I'm joined today by Dr. Nadeem Rahman, and we've been talking about all things prostate cancer. So just before the break, Dr. Rahman, we were talking about essentially the grading system when it comes to prostate cancer. And I love the level of detail that you gave us as far as understanding and breaking down some of the numbers that we can see on reports after biopsies are done. Moving to the next step, which involves treatment, of course. I want to start by asking you, do all cancers of the prostate need to be treated? Because even though I know the answer, a lot of people may be surprised to hear the answer to this question.
Yeah, no, that's a great question. It's a great point. I think that one thing that, the word cancer oftentimes gets everyone scared, and people are always wanting treatment for cancer, especially when they're diagnosed. And one of the things I always have to emphasize to our patients is that, treatment prostate cancer for at least 2/3 up to 3/4 of cancers that are diagnosed typically are of the lower grade variety. Mm-hmm. And we've done a lot of studies on these lower grade cancers over the last 20 years. And we know that their behavior tends to be very slow growing, and they tend to not want to spread very quickly. And as I mentioned, because prostate cancer is in such a strategic area where you can potentially create side effects, we usually recommend just watching those cancers if they're not going to cause any immediate harm, so that patients can kind of maintain their excellent or same quality of life rather than go through a treatment that may not immediately benefit them, but then have to suffer through some of the quality of life issues that occur. So up to 2/3 to 3/4 of men who are diagnosed with these lower grade prostate cancers typically can go on what's called active surveillance, where we just monitor their PSA levels. We monitor the rectal examinations. We follow up imaging with MRI scans or further biopsies, and we monitor those cancers until they do change to a more aggressive variety that would then require treatment. And many times they may not. They may go 10 or 15 years and not require treatment at all. So that's why it's very, very important to kind of get an understanding of the different types of prostate cancers that are out there, the differences between lower grade or higher grade cancers.
Excellent. Now, I love that you mentioned that because, of course, when it comes to medicine, again, nothing is cookie cutter. And so it's important to weigh risks and benefits when it comes to treatment as well. And when it comes to treatment for the higher grade or the more aggressive cancers, what are the options that you provide to your patients to treat that?
So I think, for intermediate or higher grade cancers, I think we're always trying for curative intent. And I think that, the most common treatment that we offer our patients is robotic surgery. So, it kind of sounds very advanced, but it's really just a type of advanced laparoscopic surgery. So laparoscopic surgery is where instead of making a big incision, which is the way that a traditional surgery would have been done for prostate removal, we make 4 or 5, minimally invasive incisions that are each ranging in size between 8 millimeters and maybe 10 millimeters in size. Through those areas, we place little trocars that are then hooked to a robot. And the machine we use is called the Davinci Robot. This allows us to kind of really get into the pelvis to access that prostate that's in a tough to access location, and kind of allow us to remove the prostate and with minimizing side effects. And so we can identify the nerve bundles that as I mentioned, are responsible for sexual function and try to spare those nerves if we can. We can identify the sphincter muscle that is responsible for male urinary control and spare that as well. And then again, have just increased magnification and maneuverability inside of pelvis that sometimes makes it harder to do so open. And so that allows us to kind of really do a very high quality surgery, try to minimize side effects for treatment, and still are able to get a good cancer cure rate. So that's probably the most common treatment that I do for my patients. We're also involved in patients who elect to not do surgery, or maybe they're not good surgical candidates, to do different types of radiation therapy. And there are several types of those that are available as well, which we can talk about.
Excellent. So I love the description of robotic surgery. While I'm familiar, I'm not a surgeon, but I've rotated and have seen it. It's brilliant. It's a brilliant piece of technology that allows, as you said, for surgery to be performed in areas that are highly sensitive or hard to reach, so to speak, or maybe you want to reduce complications. So when you talk about removing the prostate, do you always have to remove the whole the whole section of the whole prostate itself, or can you do resections of the prostate? And my follow-up to that is, if you do remove the whole prostate, what happens to all of the other functions we mentioned at the beginning of this episode that the prostate is involved in?
Sure. So, there are treatment available to do partial treatment for the prostate cancer, especially if it's localized. Those are still considered a little bit controversial in the field of urology. So most patients who have, prostate cancer and undergoing robotic surgery get a complete removal of the prostate. And, as I mentioned, even though the prostate is responsible for sexual function and for ejaculation, for a lot of making a lot of the semen for ejaculation, once a prostate is removed, those functions are definitely affected. So if a man is having intimacy with his wife and having sexual intercourse and reaches climax, after a prostate's removed, the ejaculation will be dry. There will be no semen coming forward. Also, if with robotic surgery, as I mentioned, the magnification is much higher, so you can actually see the nerve bundles to a higher degree and do a nerve sparing technique. That being said, even with that technique, there's still a recovery that's involved. A man may not still have the type of erections that he had before surgery, and may require additional medicines like Viagra or Cialis, or sometimes we actually give men injections into the penis to help with blood circulation for erection. So those functions are definitely compromised. And as I mentioned also before, the prostate, because the sphincter muscle is adjacent to the prostate and the urethra runs through the prostate, urinary control can sometimes be a factor. But with aggressive rehab and exercises, most men are able to get that control back fairly quickly.
Thank you for that. I actually had a patient who that last point that you made was an issue for this patient, but gradually over time, just like you said, and with rehab, it definitely did improve for them. Yeah. And so I just want to recap recap what you've said, in the fact that yes, there are potential complications as a result of this life-saving really measure to remove the prostate, but that there are ways to counteract some of those complications, so to speak, or those after effects of the surgery. Yeah. And so that's great to hear. One that probably cannot be counteracted is infertility that happens as a result of this, as you mentioned, since the ejaculate is dry. Yeah. And that may be something to discuss with your patient, or with the patient rather, to speak to the doctor about in relation to maybe doing something pre-treatment in order to preserve that for future children down the line, correct?
Sure. It's a very good point. As I mentioned, prostate cancer typically does affect older patients, but I had a patient today who was like 42 that was diagnosed, and we talked specifically about sperm banking ahead of time, just to make sure if they wanted to have children in the future, they'd have that option. I also have a lot of men who in their mid-60s are still interested in still having kids. And so we always have that conversation with them to say, hey, if you still want to have children in the future, you'll probably need to bank sperm and then use IVF or artificial reproductive technologies in the future to try to have children. So those are all definitely very, very good points. And, I think sometimes we take for granted that maybe a man who may be in his 40s or 50s is done having kids, but I think it's not something that we should take for granted. I'm always surprised when I ask that question on the answers that I receive. So
absolutely, it's very, very different on this side of the fence for women. Right. But alhamdulillah. Yeah. So before we wrap up, I definitely want to just touch on recurrence, because treatment can be very intensive, as you mentioned, depending on the staging and things like that. And so is there a risk for recurrence? You mentioned that you're removing the whole prostate, but if they do not have that surgery and they go for radiation or chemotherapy, what is the risk for that?
You're absolutely right. There's a risk of recurrence for all grades and stages of cancer. Typically, the higher grade of cancer or the higher stage of cancer, the risk of recurrences are proportional to that. So we always kind of counsel patients based on what we find at the time of surgery, or if they like to have radiation. We have a lot of what are called nomograms, which are just calculations that are based on your cancer features that we can plug in, and we can give a statistical interpretation of what their risk of recurrences are. So, and then that's where, the PSA test is still so vital. We utilize that test on a monthly basis when we're talking about recurrences. We always check to see what that PSA number is. For instance, if you've had your prostate removed, you really shouldn't have any PSA production at all. And if you get a PSA test and if it's not zero, then that can sometimes lead to cancer recurrence identification. We call that a biochemical recurrence because it's based on just a test alone. Similarly, for radiation, if someone were to choose radiation, and there are different reasons to choose radiation, which we don't have time to talk about today, but if they were to choose radiation and their cancers were to come back, we would see rises in their PSA number as well. And so those are all tests that we utilize to test for recurrences. And then based on the level of recurrence that a patient may have, the treatments are quite variable. Sometimes you would be a candidate to do other local therapy if we suspect that the cancer that recurred is still where the prostate used to be, or for radiation in particular, if you think the recurrence is in the prostate that was left behind after radiation, you can do local therapy. I do a lot of those with either cryoablation, where you freeze the prostate, or something called HIFU, where you use focused ultrasound beams to kill off the rest of the prostate tissue. We can also then, if the cancer were to, come back in distant areas, we typically go on hormonal therapy to stop a man from making testosterone, because testosterone is so important in progression of prostate cancer. So many times the chemotherapies that are out there, or the medications that are out there to treat prostate cancer, have to do with decreasing a man's testosterone production, or decreasing the ability for a prostate cancer for making testosterone. So those are all kind of different types of things that we look at when we look at a recurrence of prostate cancer.
Well, that's very reassuring. I'll say that, at least, that if there is a chance of it coming back, that there's so many ways and I guess surveillance in place to make sure that it's caught early and that it's taken care of. And of course, it's really important in choosing the right provider for that as well, or physician. And so definitely check out Dr. Rahman's website, as well as the other one that he posted, auanet.org.
Right.
Thank you so much, Dr. Rahman. We really appreciate you taking the time, especially as I mentioned during Prostate Cancer Awareness Month, to talk about this important topic. And hopefully we've shed some light for our audience as far as who should be getting tested, when, etc., and to have that discussion with their physician. Thank you again for joining us, and we wish you every success.
Thank you for having me. It was a pleasure being on.
Thank you for joining us on another episode of What's Up, Doc. You can watch our other episodes on our website at muslimnetwork.tv and on our YouTube page at youtube.com/Muslim Network TV. I'm your host, Dr. Aalia Al-Barwani, and I'll see you next time on another episode of What's Up, Doc.